The patient has started on your chosen antibiotic. Later that day, his laparotomy was performed. The findings are a perforated gallbladder with multiple colonic adhesions. Aspirate samples are sent to the lab for microscopy and culture, and while waiting results, NM is continued on his empiric antibiotics. So which one is actually better? Single, double, or triple therapy for intra-abdominal infections? Well, let's take a look at a single therapy with tazocin. This is a free-range and warm-bodied antibiotic. It has broad combination of gram-negative, gram-positive, and anaerobic cover. It is a good choice for those with delicate kidney or delicate hearing. However, it may contain traces of inducible resistance. Then there is double therapy with ceftriaxone and metronidazole. This is the narrowest spectrum of the three, consisting of a light-bodied combination of gram-negative and anaerobic cover. It is also good for those with delicate kidney or delicate hearing. However, it does not cover Pseudomonas, escapem, organism, and provides only limited cover against Staphylococcus. It also has high levels of inducible resistance. Then there is triple therapy. This is the broadest spectrum combination. It covers escapem, organism, and Pseudomonas. It has a potent combination which allows penicillin and gentamicin synergy, as well as post-antibiotic effect with gentamicin. It is not recommended for those with severe renal impairment, vertigo, or hearing loss, or for suspected staph infection. Resistance is uncommon for this combination.
I know the answer. It has to be ceftriaxone and metronidazole. That has the narrowest cover.
Well, in this case, it's actually the broadest spectrum option which is recommended. If we check the therapeutic guidelines, triple therapy is first line for perforated viscus and for severe diverticulitis or appendicitis. If the patient cannot tolerate gentamicin, then the next best option is tazocin. If the patient cannot tolerate a penicillin, then the next best option is ceftriaxone and metronidazole. This is because ceftriaxone has limited cover, with a large number of organisms intrinsically resistant to ceftriaxone, such as Enterobacter and Enterococcus. Gentamicin also has the added benefit of providing a post-antibiotic effect. If we look a bit closer, we will see that even though triple therapy is providing the broadest cover, it is doing so with a number of antibiotics. This way, if resistance does develop to one agent, then we can usually still cover with a broader spectrum agent. However, if we start with a broad spectrum agent and resistance develops to that, then it is unlikely we will be able to use a narrower spectrum agent for that infection.
Why don't we always use triple therapy?
Well, gentamicin won't blend with every condition. If a patient has gentamicin allergy, they can't have gentamicin. If they have myasthenia gravis, they can't have gentamicin. If they have previous vestibular or auditory toxicity from an aminoglycoside, then they can't have gentamicin. If they are critically ill, they have severe renal impairment, pre-existing auditory or vestibular toxicity, or advanced age, then gentamicin is not a good choice either. For all other patient groups, gentamicin is a good option. At the moment, gentamicin resistance is rare in tests. If resistance to gentamicin does develop, then we have ceftriaxone or tazocine available as alternatives. But if we develop resistance to these first, by using them for all our patients, then when our patients become older, we cannot replace these agents with gentamicin. Now please complete second set of questions.